Hello, and welcome to the latest in our Go Diabetes webinar series. The topic today is the Patient Experience Study. We have two outstanding faculty members who have taken the lead role in this Patient Experience Study. The first presenter will be Sherilyn Sloan Arnold, and the second will be Patricia Gilliam. For all attendees, your phones are muted at this point in time and will continue to be muted throughout the presentation. We will ask you to hold questions till the end of the presentation, and at that point use the chat function to ask any questions. And I'll give those instructions again at the end of the webinar. As I said, Sherilyn Sloan Arnold is the President and Chief Learning Officer of Integrated Learning Partners, based in Westport, Connecticut. Over the past 14 years, Sherilyn has held senior leadership positions in healthcare, pioneering performance optimization, and e-business solutions. She is recognized for designing award-winning educational research, performance improvement, patient health, and medical education solutions for specialty medical societies, academic centers, and pharmaceutical manufacturers in the United States and globally. Sherilyn is also a performance improvement practice champion for Joslin Diabetes Center. In this role, she provides consulting services to primary care practices throughout the United States, helping them to improve team-based care and implement continuous quality improvement programs to improve type 2 diabetes clinical measures and patient health outcomes. As I said, our second speaker will be Patricia Gilliam. Patricia is a doctorally prepared nurse practitioner. She's an associate professor of nursing and the director of the Accelerated Baccalaureate Nursing Program at Western Carolina University in Asheville, North Carolina. She has over 20 years' experience in the areas of nursing practice, research, and education. She has been working as a nurse practitioner for over 12 years, providing primary care to patients living with HIV disease. Her research focuses largely on the process of transition for adolescents with HIV disease from a pediatric adolescent care setting to an adult care setting. She recently completed a project for the National Center for HIV Care in Minority Communities, where she developed a curriculum to train medical providers working in federally funded community health centers to enable them to provide various levels of HIV care within their primary care setting. Over the last 2 years, she has worked as a clinical specialist for Integrated Learning Partners in West Point, Connecticut, and she has been involved in numerous continuing education and quality improvement projects that are designed specifically for primary care and family practice providers. The presentation today will be to outline and then share the results with a pilot study that was new this year to our Go Diabetes project. And with no further introduction, Sherilyn, go ahead.
Thank you, Susan. Thank you. As Susan mentioned, myself and Dr. Patricia Gilliam will be your presenters for today. We will be reviewing the Go Diabetes Patient Experience Study project with you. I'll start by providing a general overview of the project. Then Dr. Gilliam will talk about key findings we identified during the baseline study, which was Survey 1, and talk about how the information guided the development of the educational interventions. Dr. Gilliam will then review the project's educational goals and share with you some of the materials used in the interventions for both providers and patients. I'll then talk about some of the Survey 2 highlights and the impact the study had on participating providers and their patients. We'll then answer any questions that you might have. So let's get started with the project overview. The research study team consisted of myself, Dr. Peter Gamache, who is our research specialist. Dr. Gamache worked closely with Dr. Gilliam on the development of the survey instruments and data analysis. Dr. Gilliam and I worked on the design of the educational interventions, and Ms. Catherine Griffin worked closely with me on the project management and coordination of the deliverables. Ms. Griffin was instrumental in managing the day-to-day tasks and was the primary point person responsible for patient recruitment. I'd also like to add that in addition to Dr. Gilliam, we had 2 guest faculty members from Joslin Diabetes Center participate in the provider training webinar. Ms. Bunn Sr., who is a manager of educational programs at Joslin Diabetes Center, and Ms. Jackson, who is a project manager at Joslin, both possess over 20 years' experience working in primary care, and they're currently seeing patients on a part-time basis, both at Joslin and in community clinics. Regarding provider and patient participation, we had a total of 22 providers participate, representing 8 practices throughout the United States. We also exceeded our goal of recruiting 65 patients and had 81 patients participate in the study through to the intervention phase. Due to attrition and practice staffing changes, we are experiencing a drop-off in Survey 2 participation, and this is specifically with regards to the patient numbers because there are some providers who had left their practices, and so we could not continue these patients on in the study. The objective of this study was to determine satisfaction relative to type 2 diabetes care the patients received and to assess the impact of integrated learning between clinicians and patients. Our goals were to improve providers' communication skills with patients, enhance patients' knowledge about type 2 diabetes and their self-management skills, and assess and improve the patient care experience. This slide highlights the timeline and the study design. As you can see, there are 2 pathways, one for providers and one for patients. We experienced some delays with patient recruitment, hence had to extend our timeline through September. In addition, interventions and follow-up were dependent on patients having scheduled follow-up visits with their providers within a 3-month window, so we had to take this into consideration. We worked closely with office staff to ensure follow-up appointments were scheduled, and we are currently in the final stage, step 7, with completing both the provider and patient surveys. Let's talk about some recruitment goals. Regarding our recruitment goals, we recruited practices between February and March 2012. Our goal was to get 6 practices, and we were able to recruit 8. Each practice identified 2 to 3 providers to participate, and each of the providers had approximately 5 patients participating. We had 22 providers participating in this study. With regards to patient recruitment, our recruitment timeline was between April and May 2012. The criteria for patient recruitment included that patients had to be older than 21 years old, they had to be diagnosed with type 2 diabetes, seen in the practice for at least 6 months, have no severe comorbidities. We did not include non-speaking patients and did not include patients who were terminally ill. Patients were required to complete a patient consent form, and like I said, we exceeded our goal and had 84 patient participants in the study. The patient recruitment process was very controlled. We worked with front office staff who handed out study recruitment materials and patient consent forms. ILP then followed up with the patients directly. Patient participation was blinded to the providers. All participants received a $15 gift card to either Walmart or Target when they completed the survey. And to motivate patients, we incentivized them with a chance to win a $50 gift card for completing both surveys by a set date. This seemed to help, and what you see on the right-hand side of your screen is just an example of the patient consent form that we used. Patient participants were predominantly white. However, 15% self-identified as Black or African American, 20% were Latino or Hispanic, and 3% Asian. If we take out the white population in this sample, the Black, Latino, Hispanic, and Asian populations mirror that of the fastest growing populations of those diagnosed with type 2 diabetes in the U.S. today. In addition, age also mirrors U.S. statistics, with the majority of patients being 41 to 64 years old, and the second largest population in this study being older than 65 years of age. What I wanted to do with this slide is just highlight for you a little bit about the methodology. The project was sequential in that every phase or step related to the next. Pre-survey instruments were used to assess and qualify practices. Then we had a series of training webinars to review the project with the practices before we received formal commitment. We also worked with office staff and patients to maximize recruitment efforts. And formal and informal surveys, as well as phone interviews, guided the development of the pre-intervention survey, which is Survey 1. From there, data from the survey guided the development of the educational interventions. The interventions were customized to meet the unique needs of both providers and patients involved in this study. Intervention formats included print and online training tools that consisted of one-page fact sheets, print brochures and guides from the American Diabetes Association, Joslin Diabetes Center, and other organizations. In addition, providers participated in a training webinar in July. And in this webinar, we focused on teaching strategies and tactics for providers to use to improve provider-patient communications and patient adherence, self-management, motivational skills. Dr. Gilliam will review these in greater detail a little later on in this presentation. Lastly, the final post-intervention survey, survey number 2, is concluding this week. This survey was designed to assess the impact that the educational interventions had on provider skills and practice behaviors, as well as assess patient knowledge and communication improvement with their providers. With that said, I'd like to pass the baton to Dr. Gilliam, who will review with you Survey 1 results. Dr. Gilliam?
Thank you, Sherilyn. Good afternoon, everyone. I wanted to begin this report of our results with a brief look at the key findings from the first survey, which was the pre-intervention survey for both the providers and the patients. We asked questions about assessing health literacy, a choice of checking for grade completed in school to more formal tools of health literacy, and the providers said that they did not assess for health literacy, the majority of them, which was a little surprising. We went on later to ask why this was not being done in the practice, and there were a variety of responses for that. They also did not use any type of brief intervention and brief counseling techniques in general, nor did they use motivational interviewing specifically. We provided a list of common challenges to adherence and asked them to check all that might apply to their patient population. These results are interesting, and I'll share those with you shortly. 64% of these provider practices had an EMR system in place and were currently using that system. Interestingly, though, 56% of these providers that had an EMR responded that they felt the patient educational materials that came standard with their system were not adequate. You know, I'm not sure we mentioned earlier, but about half these practices settings were private practices, and the other half were residency programs in family practice. And so that kind of gives you an idea of how much increase in use in the EHRs there is in both the academic settings and in the private practice. And finally, 63% of the providers indicated that yes, they do consistently assess for their patients' understanding of the materials that they're being taught. From the patient survey, we found an overwhelming 98% were pleased with the quality of care. We gave them a chance to actually write ad lib and independent projects or comments about their providers, and there was not a single negative comment among all of the patient surveys that were returned. They did not always, however, understand their diabetes management plans or the goals for their particular measurement of success of the plan. They were confused about meal planning, certain medical terms used during the exam and during the teaching, and also confused about the correct process for foot care. Next. When asked specifically if they're providers, could you advance the slide for me, please? When asked specifically if their providers asked them if they understood their treatment plan, and did the provider ever ask them to explain their understanding of what they were supposed to do and when, the overwhelming number of the patients said no. In this slide, it kind of parallels what we said in the key findings with more specific data. When I said it was interesting, we looked for the disconnect or discordance between provider responses and patient responses to questions that were mirrored to reflect the same question from the receiver of the specific message or instructor from the sender of the message, who was the provider. We asked several questions about techniques and specific tools used by the providers, and we also asked about specific topics that were included in the patient teaching to diabetic patients. A little over 79% of the providers did not use any formal mechanism to assess health literacy. When asked about checking for understanding, only 13% said they always checked for understanding, and 29% said very often. That leaves over half of the providers that sometimes or rarely check for understanding using the teach-back or return demonstration methods that are primarily advocated methodologies today in both medical and nursing programs to help better assess and collaborate in the development of management plans for patients. Next slide, please. We talk about, looked in this particular slide about the use of motivational interviewing techniques, and again we see that's a problem. In the provider survey number 1, we asked the providers about their use of specific challenges, or what they found as specific challenges. And this slide shows the major challenges indicated by the providers. They were able to select one or all, or as many as they thought were applicable. The challenges that are bolded are the ones that were most prominent in their responses. And you can see that the patients who are not ready to make lifestyle changes, there was a 91% of the providers selected that particular challenge. 87% selected patients who are unable or unwilling to adhere to their treatment plan as perceived by their providers, and over 95% of the time recognized or cited that they had a lack of time for either counseling and education. Some mentioned competing priorities during the visit, and so that kind of sums up what they were looking for or had cited as their challenges during this project. Motivational interviewing, however, addresses several of these issues, and that was one of the reasons that we were interested in presenting this information to the providers. It's used to determine if a patient actually values the new behavior, identifies if the patient is ready to make the change to adopt the new behavior, and provides information that can assist the provider and the patient to improve adherence to any new behavior associated with their diabetes management. Moving on to the patient responses. Next slide. Should be patient survey number 1, general questions. We asked the slide 19. We asked the patient some general questions, such as, did the provider spend enough time with you during the visit? Did the provider listen to your explanations and questions carefully? Did the provider answer your questions to your satisfaction? What is the degree of trust you have in this provider? How would you rate your overall experience? And would you rate the services of this provider to your, would you recommend the services of this provider to your family and friends? Only 2 of these questions were yes-no questions, and the rest were measured on a 5-point Likert scale. The overwhelming majority, greater than 95%, rated their provider on the highest positive response available for them to select. There were several opportunities for them to write out comments, and there was not one negative statement in all of those pre-intervention surveys, which was pretty incredible. It's obvious that the providers participated in this patient experience study were already doing a great job of providing high-quality care to these patients. Next slide, please. We asked asked the patients to identify certain challenges that they had in adhering to their management plan, and this is a list of the challenges that they could select from. And what they said was, again, the ones that are not, it's kind of hard to see the ones that are bolded, but the challenges that were selected by the majority of the patients were they found it challenging to accurately explain their diet to their provider that they had used or had intake over the past 3 months since their last appointment. They found the diabetic diet too hard to follow. And interestingly, many of them suggested that they were not able to afford their home diabetes testing equipment, either their meter or their strips. A fairly large number, but not a majority, said that they were also not able to understand medical words related to diabetes. And we went on later to find out some specific things that they had problems understanding, and it came out that they some of the terminology included BMI, LDL. I think another one was high-density lipoprotein as well. So there could have been some confusion about whether those topics, when we were talking about cardiometabolic syndrome, that we talk about as providers, if those were talked about, and hypertension was another one, if those were talked about separately as separate disease states, perhaps, and so the patients didn't equate that to being a part of their diabetes, or if it was, in fact, an actual misunderstanding or lack of knowledge of what those words meant. We also couldn't determine from the structure of the questions and responses exactly what the patients had difficulty explaining to their provider or what part of the diet was too hard to follow. It could have been related to counting or measuring carbohydrates, portions or calories, interpreting labels, the cost of fresh foods that are recommended, vegetables and fruits in particular, or the difficulty in preparing these healthier meals. And it could also have been related to some environmental or social issues. Next slide, please. We all realize that daily foot checks are critical to preventing complications in our diabetic patients. We were surprised about the response to this particular question, and I include this as actual numbers of patients that either check their feet daily, weekly, monthly, or never. And these are not percentages, they're actual patient numbers. The providers on their side believed that they addressed foot care at every visit, but for some reason the patients on this side didn't seem to listen or ignore or just not take into account the significance of checking their feet daily. 37 out of the 81 that answered this question said yes, they do check their feet daily. 27 check their feet weekly. 9 check their feet monthly, and 8 said that they actually never do check their feet. So in this small sample, over 50% of the patients don't check their feet every day. This example, next slide. This example that I just shared with the actual data about the foot checks is an example of how we selected what patient information to contain in the toolkits. We had certified diabetic educators from Joslin that Sherilyn mentioned a few minutes ago that used their years of expertise teaching these specific topics and refining and honing those skills with literally probably thousands of patients to offer up to these providers, their expert opinion of how best to ask the questions. And they certainly have a firm foundation in the use of motivational interviewing to help patients make these lifestyle changes in diet and in the frequency of their physical activity, in other life-changing lifestyle modifications. So they were able to present and offer some of the language that they use that they have found most successful in helping patients succeed in their own self-management. Next slide. They started their presentation with saying that effective communication is the foundation for all diabetes self-management. And the question is, again, how do you do that? How do you do it, and how do you do it effectively? The provider webinar that we offer to the providers focused not only on specific patient education topics, but also on communication and teaching skills that could improve these providers' delivery of the specific diabetes information. Next slide. I am getting to my next slide. Okay. Is this the slide that is topic educational focus for you guys? The educational focus of our toolkit and our entire integrated learning educational intervention we wanted to improve provider-patient communication skills, assess patients' health literacy, counsel patients on specific lifestyle changes, and these included things related to nutrition such as meal planning, food selection, physical activity, which is a term that is being promoted rather than exercise, and we may get into that if we have time in a little bit, medication adherence, and blood glucose monitoring. This was all designed to improve patient adherence to their own self-management plans and put the patients in control of managing their health and their diabetes. Next slide. Teach-back is a method. As I said, it's being taught in medical communication, nursing communication, and it's asking patients to repeat back in their own words what they need to know or do, and it should be done in a non-shaming way. Remember, we used patriarchal terminology and tones for so many years, and now we're trying to move into a newer style of collaborative management of disease with our patients. This teach-back is not designed to be a test of the patient, but of how well you or the provider explain these concepts. It's an opportunity to check for the patient's understanding, and if necessary, if they don't understand, you need to reteach or teach it in a different way or use different words or do something to facilitate their understanding. Otherwise, they're not ever going to be able to be successful in their self-management. Next slide. This diagram talks about what is considered the 4 pillars of diabetes self-management: nutrition, physical activity, medication, and blood glucose monitoring. And again, as they said, these comprehensive pillars are the information to provide for patients is never going to be effectively heard and assimilated in the patients if the providers don't use effective communication techniques. I seem to have lost a screen for just if you could give me just a moment, I'll get that back up.
We're on the plate method.
Okay. It's not, I mean, my whole screen just went blank, so please bear with me just for half a second. And help me out with what slide number that is.
On the plate method slide?
Yeah. Okay. Okay.
While Patty's pulling up her presentation due to technical challenge, I just want to mention that the experts at Joslin, specifically Sharon Jackson, who is a registered dietitian, would talk to the providers about the migration from using the old food pyramid to using the plate method, especially for this study, because a lot of the patients demonstrated that they had trouble visualizing or understanding how they should create their meals. So the plate method, which is being advocated by the American Diabetes Association, is being highly recommended. And as you can see, it gives patients a good visual to fill half their plate with vegetables, a quarter with a protein, and another quarter with rice and beans, or starch, I'm sorry. In addition to supplement their meals throughout the day with fruit and vegetables. Patty, are you?
No, I'm not quite there. Why don't you go ahead to the next slide.
And because patients had a challenge with being able to recall their meal plans for the last 3 months, we found that using a food and activity record would be most helpful in to help patients keep a log of their daily mealing plans. This functioned as a tool so that when patients come to the office for their follow-up visit, they could review their meal plans and what they ate with their providers. This will help the providers and help you discuss what foods were good and what foods maybe were not so good that were consumed by the patients. This also helps with assessing some of the blood glucose values and talking to patients about that. In addition, as Patty mentioned, the discussion really is not about focusing on exercising, but talking to the patients of how they could integrate physical activity into their daily lives. And what both Sharon Jackson and Patricia Bonsignor spoke to the providers about during the training webinar was possibly developing the RX for healthier living, basically providing their patients with prescriptions. Data demonstrates that having prescriptions for activities, etc., help with patient compliance. And patients feel that, okay, these are doctor's orders. It helps with instructions and follow-up. And then in follow-up activities similar to the meal planning record, there's also a physical activity log that was shared with both the patients and the providers in the study that is being used to log physical activity. Their goals were to exercise 3 to 5 days a week or walk 3 to 5 days a week, and ideally walk 10,000 steps a day.
I believe I'm back together.
Okay, we're on suggested video resources for patients.
Yes. Please excuse my technical problems today. I'm having to work off 2 different computers, and I'm asynchronous to the webinar. And it's definitely my server's issue. So on this slide, we had asked the providers and the patients about their preferred methods of learning, and were surprised a little bit that patients as well as the providers wanted some video, some online video materials, and some online interactive websites. So we tried to compile a list from a variety of, reputable and vetted sources. Of course, we used some things from Joslin's Diabetes Center's patient and provider site, from Health and Human Services, from CDC, from NIH, from the ADA, as well as some of the myplate.gov and some of that comes from HHS and the Get Moving physical activity program. The videos were innovatively used because they could either be in the waiting room, or they could be actually in the patient's room, where you could the person that's rooming in the patient could ask, what particular topic might you want to see a short video of, and could queue it up either on a video player or on some type of monitor that's actually perhaps even integrated into the electronic health record system that's in each patient rooms. Then following the visit and during the visit, there were corresponding paper pamphlets and one-page fact sheets and such that were related to the videos that the patients could actually walk out with and take home. Next slide, please. This is kind of a summary of the educational intervention, which we called the Integrated Learning Package that we provided for both providers and patients. For the providers, during June and July, we offered a training webinar. And again, I talked a little bit about just general communication techniques and the importance of being specific, the sender, the receiver, quality, good listening skills. And Ms. Bonsignor and Ms. Jackson shared the specifics, as we said, from their years of experience as certified as CDEs at Joslin. We included the communication techniques. We talked about lifestyle counseling, how to set SMART goals with their patients. In the toolkits for those providers, we included a selection of patient assessment tools that could be used by the staff or the provider, and also the same collection of patient education materials that we sent to each individual patient in the study. There were links to some CME activities that the providers could choose to complete, and then as I said, it contained an identical set of the patient education materials. Next slide, please. And for the patients, we tried to include a comprehensive list of all of the topics that covered the pillars of successful diabetes management. Even though we didn't get really to blood glucose monitoring and some medications, we went ahead and included some of that information in the patient education toolkit package, along with some suggestions that will hopefully help them improve their own self-management. We targeted another, I think we showed you a minute ago, the food and activity log, making healthy food decisions, and also something about purchasing food on a budget. So we tried to include something that would maybe touch, all of the different groups that were represented in our patient population. And with that summary of what we did for providers and patients, I'll turn the baton back over to Sherilyn, who will talk about where we are currently with bringing in the results from Survey 2 and looking at a preliminary data analysis. Thank you, guys, and again, my apologies for my difficulties today. Hello?
This is Susan. While we're waiting for Sherilyn, I'd like to remind you all that we will hold questions until the end, and questions can be answered or asked by using the chat function, and that way we can read the questions and they will be included in this recording of this webinar. Sherilyn?
I think last week was a full moon, but you could really not prove that by me with every challenge that we've had today.
Okay.
Until Sherilyn comes back online, let me try to go through her set of slides. First, the results of Survey 2. As we look at this first slide, titled, we should be on,
Providers' Commitment to Assessing Health Literacy.
Okay, thank you. We asked the question, are you more likely to use formal tools to determine your patient's health literacy? And if you remember, almost none of the providers used anything, not even what grade the patients completed in school, but after participating in the informational webinar and actually having a validated 2-question health literacy tool given to them, 91% of them said they now do check for their patient's health literacy, which is so important in selecting the level of materials that you're going to be presenting to the patient. And in our next slide, we looked at do you plan to use additional patient education materials? And what is the source of those particular patient education materials? And this was somewhat based on using ones that were outside the electronic health record. And 91% of the providers said that yes, they do plan to use additional tools, and a large percentage of the providers indicated that they wanted to combine a personalized selection of educational tools in a folder in their EHR that was their particular set of materials. And over 90% of the providers responding so far also indicated that they wanted to include all of the informational tools, patient education tools that were sent in the patient education toolkit. Actually, that's explained in the next slide, please. The improved usage of patient education materials despite their EMR, I said 90, but it's actually 80%, allowed individual providers to make a personal favorites folder, and they wanted to add the materials provided by the Go Diabetes study faculty to the EMR. Next slide. We offered them a list of techniques that were new to them based on the comparison between the pre-survey number 1 and the post-survey or post-intervention learning package. And it says, after participating in the Go Diabetes webinar, which of the following techniques do you plan to implement? And we see a great commitment from the providers. Over 90% will begin the assessment of the patient's baseline knowledge of specific topics related to diabetes management, because if you don't know where your patient's baseline level is, you really don't know where to start, and you could be wasting some valuable time starting every patient at step A when some of them may be at B or C, or you think that the patient's had diabetes for a number of years and they know this material, which in fact they have never been taught and don't know the material. So an appropriate baseline assessment is very important. Also, over 90% of our providers said that they would begin to look at readiness to adopt specific lifestyle changes. That's a component of motivational interviewing, because we can talk as providers and teach and coerce and plead and bargain till the cows come home, but until a patient has decided that they are ready to make a change, and there's actually a quantitative measure of readiness until they're ready to make the change, we need to set up ways to improve their readiness rather than take our valuable time with our patients to present information to change when they're not ready. Also, when almost none of them, before the learning package used the teach-back method, we see that 80% of them will begin to use the teach-back method to help assess their patient's understanding of the materials. And the difference, I don't think I mentioned, between a teach-back and a return demonstration is simply that the teach-back technique is used for information, just explanations in words, whereas a return demonstration is actually of some of the skills that are absolutely necessary for successful diabetes management, such as how to use your glucometer, how to correctly read and interpret food labels. And those were some very satisfying results when we began to look at these Survey 2 results. Next slide, please. Let's see. We always ask in continuing medical education programs about changes in level of confidence of performing certain skills or including certain practices into your daily practice of care. And we ask, and you can see from this graph that when we ask following the diabetes webinar and review of the toolkit, please rate your confidence, your rate of change in confidence from before and after as a result of participating in the study. And rather than read through these, because I think we're getting obviously a little bit past time, I'll just let you read through these. But the blue and the orange areas that indicated extreme or moderate change certainly were the predominant choices. Next slide. discussing patients' experiences with meal plan discussions, we asked them that during the last visit that you had post-intervention, did your provider speak to you about meal planning? And we see that this wave graph is certainly slanted over to the very often and always category. And the next slide, we hope we have increased the numbers of people that are doing discussions of foot care, as well as getting the appropriate message and the significance of that across to increase the numbers of patients that are doing daily foot checks. Next
and
slide.
Patty, I'd also like to add that we feel this correlates directly back to the Teach Back training in the provider webinar, since we focused on meal planning and checking for foot problems and the importance of doing so.
Okay. Welcome back.
Thank you.
I'll let you take over your slides.
Okay. Well, we asked patients' perspective on providing or using Teach Back, and when we asked them if their providers were using this method during their last follow-up exam, 50% of the patient participants said yes, and we're hoping that this will continue as data suggests using Teach Back strategies or techniques truly help improve patient engagement and adherence. Also, with this slide, we wanted to demonstrate the patient's perspective of the usefulness of the toolkit materials. And so we asked patients if they found the Go Diabetes Patient Experience Study Toolkit materials were useful, and more than 80% found them useful to very useful. And specifically, they preferred the print materials, the 1 to 2 page fact sheets, over some of the larger brochures or web-based resources. They also indicated that they took the meal plan and the glucose monitoring fact sheets back to their provider's office during the follow-up visits. So we also wanted to know if there was an increase in provider-patient dialogue after participating in the study. And I'm happy to report that more than 90% of the patients responded that they are having more extensive dialogues with their providers about the diabetes self-management plans, which secondarily is resulting, hopefully, in improved patient experience and satisfaction regarding the quality of care that they are receiving. And as Patty mentioned earlier in the presentation, that we really started off the study with patient satisfaction scores being in the 93 to 95%, and that their patients indicated they had strong and trusting relationships with the providers who participated, so that the providers in this study were doing a great job. What we're seeing with some of the preliminary data from survey number 2 is that they're doing an even better job. So we just want to congratulate everybody in the study and encourage them to keep up the good work, because we hope this will continue in meaningful dialogue that is going to assist patients in achieving their treatment goals and for their diabetes self-management. And now, if time allows, I think we may have some questions or have time for questions, so I'm going to pass the baton to Susan Reichman.
Thank you so much, Sherilyn and Patty. At this point, if you do have questions of either one of our faculty, if you will use the chat function and type those in, we will read those aloud and then respond to the questions. Again, wanted to make sure that everyone knew that this webinar is being recorded, and it will be posted within a week on our website, which is www.godiabetes.org. And you will find all of the webinars posted under resources, and certainly encourage you to share that information with your colleagues at some point, because there have been several very interesting presentations given, and that can be very useful in your care of your diabetes patients. Again, if you have any questions, you can go ahead and put those in the chat function. We do want to encourage you to use our website. It does have resources with past issues of our newsletter, Go Diabetes, News on the Go, as well as the webinar and additional resources. At this point in time, I don't see any questions. So I want to thank each of you for your participation in this activity. Thank our faculty for their interesting presentation, and we appreciate your attendance. Thank you. This ends the webinar.